Hi, everyone. Before we begin, I'm going to go ahead and introduce our wonderful panel members over here on the side. Starting over here directly to the right, we have Dr. Gabor Mate, who is from Vancouver, British Columbia, although originally from Budapest, Hungary, and almost needs no introduction. As a medical doctor, he's worked in both family practice and palliative care for over 20 years. And it is specifically his work as the author of this year's compelling and for some controversial common book in the realm of hungry ghosts that he's come to the UW to share his experience and perspectives on the origin, psychology, and hopes for treatment of those with drug addiction. So welcome.
Thank you.
Dr. Caleb Bantagreen, immediately to his right, is a Seattle native who received his PhD in health services research at the University of Washington, now performs research at UW's Alcohol and Drug Abuse Institute. 2012 was a big year for Dr. Green. He received an impressive 5-year grant to develop and test an overdose prevention intervention at Harborview, and he served as a scientific advisor in the executive office of the president. Dr. Ruby Takushi, immediately to his right, is from Hawaii and received her PhD in clinical psychology from the Fuller Theological Seminary in Pasadena, California, and is now busy balancing work in a private practice setting with being director of programs at Seattle's Recovery Cafe. In the past, she has served on the faculty of Howard University and the board of the Evergreen Council for Problem Gambling. And finally, last but not least, we have Mr. Frank Couch on the far right, who is another Seattle native who received his master's degree in psychology from Antioch University in Seattle, and now acts as director of the Science and Management of Addiction, or SAMA Foundation, where he chiefly manages the clinical programs in addition to seeing patients. So before we begin, I'd like to allow each of our panelists about 3 to 5 minutes each to more or less freestyle about whatever they would like to regarding social health equity, addiction, or any sort of other issues we face here in Puget Sound. Would you like to begin?
Thank you. Well, I'd like to begin with a question. I get that everybody likes my book. What's the controversy about? Actually, I'm asking, what is the controversy about? You said it was controversial, and I'm just wondering what are people questioning? And I don't mean argumentatively. I just would like to know what the issue is for people.
I think that a lot of it comes from the harm reduction model versus the abstinence model.
Okay, great. So then that's a great thing to begin with then. Thank you. So the very phrase, the harm reduction model versus the abstinence model, assumes that these things are somehow opposite, that they're somehow in contradiction to one another. In fact, there is no contradiction. The ultimate goal, if it's achievable, for anybody that works in supporting people with addictions, is that they should become abstinent. Not only that they should become abstinent, but also they should become sober, which is not the same thing. There's a lot of abstinent people who are not at all sober. They're not using the drug, but they haven't dealt with their addictive tendencies at all. They just transfer it to something other than the drug. So the ultimate goal is sobriety, and the secondary goal, or the intermediate goal, is abstinence, and we would all love to see everybody at least abstinent. But it's not versus, because the assumption in that statement that it's versus is somehow that the one contradicts or obviates or opposes or undermines the other. It's on the contrary. A properly run harm reduction process actually helps people move towards abstinence and towards sobriety. Now, even if it didn't, it'd be justified. I mean, I want somebody here who might not support harm reduction to stand up and explain to me, why is it better that people should inject with puddle water in the back alley than with straw water and a clean needle given to them at harm reduction facility? Why is it better for people to rely on illegal drugs than to be given legal heroin or legal methadone or legal Suboxone? Why is it better that people should have to break the law for a habit that is toxic to themselves and perhaps to others? So where's the controversy here? Why is it better? Is it controversial that we should resuscitate people from overdoses, as we do in Vancouver's supervised injection site? If that's controversial, then why do we resuscitate people in the emergency ward when they come in with a heart attack caused by their smoking? Why we should, okay, you did it to yourself, die. So I'm just wondering what the source of the controversy is. So even if harm reduction had no other goal but to reduce the harm, that itself would be more than sufficient. If I can reduce HIV transmission, if I can reduce somebody injecting so they get a brain abscess, or an abscess of their spinal cord, or infection of their heart valves, or septicemia, a massive invasion by bacteria of their bloodstream, if we can reduce the incidence of that or the risk of that, on what reasonable grounds would anybody oppose that? And that's all that harm reduction does. But what I need to emphasize for you all is that the people that we're dealing with, who are these people? As you read in my book, those of you that have, these people are uniformly and without exception deeply traumatized individuals whose early experience of authority figures and caregivers is one of danger and abuse and trauma, who do not trust the system, and they have plenty of reason not to trust the system. Because in emergency wards and hospital corridors and back alleys and police lockup cells and high school and elementary school, authority figures have treated them with mistrust, with lack of compassion, with utter lack of understanding. Therefore, they do not trust the system. Therefore, when we say we're here to help, they don't believe us. Until we accept them exactly where they're at. Until we communicate to them that we actually get their pain, and we get that for now, this addiction is their best way of dealing with their pain. Now, we may not like it, but we accept that that's how it is for them, and we're going to help them reduce the harm from that habit. Now, that acceptance and that compassionate contact then opens up their ability to trust caregivers. Now they become more open to treatment. So even if harm reduction did not lead to further steps or did not potentially lead to further steps along the way, it would be sufficient and justified in and of itself. But the reality is, it's not in contradiction to abstinence. It's actually, for some people, a step towards it. And nobody stays an addict because of harm reduction. Nobody says, oh, okay, gee, I was going to give up my addiction, but now that there's clean needles, I'm not going to. Nobody becomes an addict because, oh, gee, there's a supervised injection site in Vancouver, so if I want to overdose, I'll go over there and overdose, and then I'll be okay because they'll save me. And now I can become a drug addict. I mean, that's just nonsense. People become addicted, and they stay addicted for complex reasons that have to do with their personal, community, and social and multi-generational history. So harm reduction does not sustain the addiction, it does not encourage it, it does not reward it, it does not promote it, it simply makes it a little bit less dangerous, a little bit less risky, a little bit less laden with disease. And if that's not our role as public health practitioners, as physicians, as nurses, then I don't know what our role is.
All right, so maybe if you want to respond to, that was actually my first question, which was, in what ways do abstinence-based policies perpetuate, actually, I'm sorry, I was wrong. Is harm reduction or abstinence-based treatment, what's sort of the controversy? If you want to keep going on that, and if you want to introduce some of your own ideas, that'd be great.
Sure. I think the thing about addiction, as opposed to a lot of other topics we talk about in school public health, is everybody's an expert. Everybody has their story. Everybody has their study. Oftentimes their study may be an N of one of their family or their friends. And so everybody is bringing a lot of their stuff to addiction. And if somebody goes out and talks a lot with police and public health folks and tribes and chemical dependency counselors, some who come from a drug-free modality perspective, I have to be very mindful of that when I'm out in communities talking with people. And it's very hard for people oftentimes. They say, oh, you're just enabling, you're perpetuating drug use. And I like to say that you're not enabling somebody to keep them alive. That's not an enabling act. That's a humane act, is to engage with people like that. And so I'll just say the premise of my grant at Harm Review, our intervention with people who are at risk for overdose, is we do an overdose risk assessment. And we don't just ask about the biological risks, we ask about the social and environmental risks. And we work with them to come up with their own overdose risk reduction plan. What are they going to do, not just about their use, but also to talk with others in their environment. And so we try to engage with them and meet them where they are, whatever it is they want to work on. It may be not mixing with benzodiazepines the next time they use. They may be making sure that other people are around when they're using. If they're using after a break, starting low, going slow, all of those things, and then giving them those tools, following up with them and giving them 2 doses of take-home naloxone, which is an antidote. And so that's sort of the quintessential, well, there's many quintessential now. There's a lot more harm reduction type things we're talking about, but one of them is overdose risk reduction. And one of the things that was exciting when I was working in DC was working with the drug czar at the time and helping him embrace that gray that people see is harm reduction, and getting him to start talking about things like you can't recover if you're dead. So maybe that's where abstinence meets up with the harm reduction, is you can't recover if you're dead. So that sometimes is a starting point that engages some folks who bring a lot of, I would just say, baggage to that conversation.
So I guess I'll start with just context of what we do and bring it back to the question of how to respond to someone for whom using drugs and alcohol makes sense. So I work at the Recovery Cafe, and we are recovery support for men and women in recovery from trauma, homelessness, a range of addictions, alcohol, drugs, behavioral addictions. And our vision is to create a community, a place where folks can come and begin the process of discovering that they are capable of healing and accepted and valued where they are. So really nothing to add to, I think, your Dr. Mate's vision of how harm reduction looks in practice, except that in our piece of building community, we invite each individual to come and get to know us and tell their story so that we can respond in a way that meets them where they are. I feel like I back up a little bit. To be a member at the cafe, 2 requirements, and that is drug and alcohol free for 24 hours and come to 1 recovery circle. So it's a very low bar. And on the surface, it looks like we're requiring abstinence for 24 hours, but we're really inviting someone. When you come back to us after 24 hours, here's where we can begin a conversation of listening to one another and us being able to hear what you need. I'm going to pass the mic, think a little bit more, and I'm sure there'll be other opportunities to say more.
Being a person that's worked in treatment addiction for a great number of years, there's several models. There's the 12-step model, which most of treatment addiction is based off of. And so when we hear that abstinence versus harm reduction, folks that have been working in the field for a while tend to be challenged by, do we use Vivitrol? Do we use a medication-assisted therapy? Or do we offer clean needles or methadone? So folks are challenged with that. At SAMA, we're not so challenged with that. I agree that we want to meet the people where they're at. What we run into a lot is young people who have multiple treatment episodes, who, for one reason or another, are unable by themselves to put it down. And our job isn't to fix them. They're not broken. What we think is our job is to give them some skills. If the starting point is medication-assisted therapy, then that's the starting point. If the starting point is just them being willing to come in and have a conversation with a therapist and to talk about what's going on in their lives, then that's the starting point. So I think that when we think of treatment, a lot of folks, when they think of treatment, they think about it in this little slice of what it is. And there's so much involved. People are so unique. People are coming to us with unique sets of circumstances. What I was challenged with when we started was that most addiction has a trauma attached to it. So that piece I'm challenged with. I read something that you wrote earlier that defined the trauma or the situation as unique to the individual as well. And so that it's not automatically assume that it's physical abuse or sexual abuse. It could be different levels of trauma or discomfort in their life, and it could come from lots of different perspectives, such as, for instance, I'm looking around this room right now, and I don't see another person in this room that looks like me. You know, not a single one. I'm the only one. And that is in itself kind of traumatic. And these are the types of things that I think you're talking about when you talk about trauma, as well as physical traumas. And but I think that that's another level of it. And I don't know that everyone that comes into our clinic has something like that. In fact, in our clinic, we're seeing folks from 13 to 29. So that's our demographic. And a lot of these young folks that we see don't have a lot to point to. They don't have a lot of lived experience. But I am aware that just being a young person in our society can be traumatic. And so in those respects, I get it. So I think I'll stop there. I think that there is a place, absolutely, a large place in addiction treatment for harm reduction. And folks that aren't thinking in that way, maybe they should recalculate their thinking.
Great. So I have another question, sort of stem off of that. And a lot of Dr. Mate's work has been done abroad and in other sort of settings. And I'm just curious, as a lot of this panel is domestic, especially in Puget Sound area, how do we translate a lot of these components or ideas, or is there not an issue of translation trying to bring these into the US and also into the Puget Sound environment?
When you say abroad, you mean Canada?
Partly.
Yeah. So close.
Well, I don't think the environment is that different, actually. First of all, in the downtown east side of Vancouver, 30% of my clients are Aboriginal origin, First Nations Canadians, Native Canadian Indians, if you like. They make up 2 or 3% of the population, 30% of the downtown east side population, 30% of the jail population. My guess is that you'll find similarities down here as well with certain racial groups. The trauma isn't, well, I mean, let me step away from the issue of trauma. So secondly, broadly speaking, it's not true that everybody who's traumatized becomes addicted, nor is it true, nor do I believe that everybody who's addicted had to have undergone trauma in that specific sense. What is true is that the more addicted you are, the more likely it is that you were traumatized. And what's absolutely also true epidemiologically, and how many of you are familiar, and this is an interesting question of School of Public Health, how many of you are familiar with the US-based adverse childhood experiences studies? Can you put your hand up? That's a pretty impressive small percentage. I mean, how the heck is it that in the School of Public Health, people aren't aware of the adverse childhood experiences studies? And by the way, a lot more people put their hands up here than usually do when I ask that question. A lot more people. So there's more awareness in this room than there's else, than in many other places. The adverse childhood experiences studies looked at 17,000 people in California. And they looked at childhood experiences, physical, sexual, or emotional abuse, a divorce, death in the family, death of a parent, the jailing of a parent, mental illness on the part of a parent, violence in the family, addiction in the family. For each of these, now, if you ask somebody, were you traumatized as a child, and if all that happened was that their mother was depressed, they would not say they were traumatized. But if you actually look at it from the perspective of childhood adversity, for each of these childhood adverse experiences, the risk of addiction goes up exponentially. So by the time a male child has had 6 of them, his risk of having become an injection-using substance-dependent addict is 4,600% greater than that of a male child with no such experiences. So the essence of addiction, I think you point to quite accurately, is not just trauma in that very specific sense, but some kind of a deep emotional and psychological and or spiritual dislocation. Separation from self, separation from community, as you alluded to, separation from nature, separation from context, from belonging. And wherever you see societies with more dislocation, and a perfect laboratory example is China today. They have this immense economic development and dislocation and an immensely growing addiction problem. What was the question? Oh yeah, so what I'm saying is, it's not a question of Canada. Wherever you see this massive dislocation, and in this society, you see it a lot, for all kinds of economic and social and historical, and sometimes those reasons have racial connotations and sometimes they don't. But in a society that massively dislocates people, that makes family life ever more difficult, that stresses parents, that makes parents less available to their children, so their children now have to develop friendships on Facebook and all this kind of stuff, you're going to see more and more addiction. And so it's not a question of Canada versus the US. This is universal, and it's totally predictable, and it works with laboratory precision. You introduce a dislocation into a society, including, but not exclusively, childhood abuse, you're going to see more addiction. And then you're going to have to approach that addiction either by very rigid and scientifically completely unfounded techniques, which is what most of what we do in the medical profession these days. Or we're going to look at the evidence and develop approaches based on the evidence.
So I'd like to pose a follow-up question that anyone can answer as well, which is how do we also focus on the changes? Well, addiction may be something that is universal. The implementation of harm reduction strategies and ways to deal with addiction can vary. How do we channel those harm reduction models that Dr. Mate has implemented and then bring those into the United States, or especially into Puget Sound?
Okay, couple things. I actually don't think it's interesting that the U.S. is that different than the rest of the world when it comes to drug policy. And we don't have safe injection facilities. We don't. Sure. I mean, there are some specific programs in places, such as safe injection facilities, parts of the UK and Canada, and we don't have those things. But in terms of like broad policies and legalization and the lack of legalization, we're really not that different. So I just don't, we're the only place besides Colorado that actually has legalization of marijuana. That's not going on anywhere else in the world. So that's part of what's going on. Harm reduction, I think the big issue with harm reduction is that, as I said, it is about embracing the gray, and it's about how to get others to do that. And what I find is when I work with people such as, I was actually with Dr. Gary Goldbaum, who's the health officer for Snohomish, 2 weeks ago, and we met with 24 police officers who prompted this meeting because of young heroin users all over the place. And there were young heroin users all over the place because of something that is uniquely American, and that is a 300% increase in prescribing of opiates. That's uniquely American, and that's sort of, you'll go from industrialization to this commodification of sort of wellness and medications, right? And that's something that we've done very well. That's where we are different. So trying to embrace that, trying to rein that thing in is something fierce to deal with. In working with police, though, it's interesting. They say these very pejorative things, and then I realized they actually don't sound any different than my friends who are ER docs. They're just wearing a different uniform. They're frustrated with dealing with the daily face of addiction. It's a frustrating thing to do. But they ultimately are about public safety. And so sometimes it's just trying to figure out what is that other person's language. Most people who are working with people who are struggling with addiction in the real world, they're either fighting it nonstop and they're getting exhausted, or they've learned to embrace that gray and have tried to figure out some way to actually help keep people alive. And so you go and try to find those advocates, you try to find those people, work with those people, and figure out what their language is, meeting them where they are, and then help that expand from that perspective. So that's how I do it when I go out into communities in terms of trying to get harm reduction more broadly implemented.
Okay, I think I heard in your question how, and what you hope is our particular take on how to implement. And I heard in your question, what does harm reduction look like in practice in my corner of the world?
Absolutely.
Sort of. So that I think I can answer. At the Recovery Cafe, part of our mission is to train and support new clinicians. So at that piece, what it looks like in practice is coaching and interacting with the student to engage with members and understand the problem and the symptom that the member or client brings to us, coaching the clinician to think about, how does this make sense to this person? It's not good, it's not bad, it just is for this individual. And what do I need to know about this member who's suffering with an addiction that will help me understand why it makes sense? Because if I don't know that, I can't come up with an intervention or a suggestion or a plan for what else might make sense to meet this person's need. So I think we don't call it harm reduction necessarily, but it's a broader way of understanding assessment, to use that word, clinical assessment, and creating an intervention that meets the person based on individual needs. And I think trauma, and we put it aside for a moment, but it comes up time and again, and it's so unique to that individual that we have no choice but to ask questions about, what did that mean to you? How did you respond at the time? Who were your resources? So that we have a sense of why this makes sense, why the addiction makes sense to the individual.
Well, let me just step a minute. So I'm going to do a bit of a perilous experiment here, and there might not be any takers, but it's in line with what you just said, Ruby. So, is anybody here that will acknowledge and is ready to do so, no pressure whatsoever, that you were abused as a child? Anybody here? I'm sure that, okay, you were. All right, great. How old were you when it happened?
No memories.
No recall at all?
Some, but
Oh.
most of it happens, and as your childhood memories dissipate, a lot of it isn't recalled.
Fair enough, but in terms of your recall, how old were you?
8, 9, 10?
So went on for a number of years.
Yes.
Who did you talk to about it?
No one.
Right. Who else had their hand up? And how old were you when it happened to you?
Throughout my childhood, I mean, as early as I can remember.
So for a number of years. And who did you speak to about it?
When
When it was happening?
it was happening, once I was an adolescent, I would talk to.
No, but
my
before,
girlfriends.
no, but before then, nobody, okay? That's where the trauma is, that there's nobody to talk to about it. Because by the time it happened to you, you had already learned that you were alone in the world and that there was no support for you. Otherwise, you would have gone to talk to somebody. So the original trauma is not even the trauma. The original trauma is that isolation, is that unprotected vulnerability. So then, harm reduction begins with asking people, okay, not what's wrong with your addiction. Let me give you a quote here. This is actually Dr. Vincent Felitti, who's the American physician who was one of the lead researchers in the adverse childhood experiences studies, which I hope you'll go home and look up tonight on the net, ACE, Adverse Childhood Experiences Studies. You cannot be public health and not know that that adverse childhood experiences exponentially increase the risk of addiction, heart disease, arthritis, homelessness, mental illness, psychosis, ADHD, antisocial behavior, marriage breakup, violence, and everything else under the sun. You can't be public health and not know that. But here's what Felitti says. Dismissing addictions as bad habits or self-destructive behavior comfortably hides their functionality in the life of the addict. You got to start with, what's it doing for you? And I did this experiment in the other room that I gave a talk to, but let's do it here. How many here will acknowledge having had an addictive relationship to a behavior or a substance at some point? Okay, just randomly. What did it do for you? What did it give you that you liked? You? Yeah.
I think it gives you a sense of comfort.
So it gives you some comfort. That means you had discomfort, and the behavior,
Yes.
and it gave you comfort. Great. What did it do for you?
Lets you relax, have a peace of mind.
It gave you peace of mind and relaxation. Who else there had their hand up? There were some other hands. Okay, what did it do for you? Mood control. Okay. One more person, perhaps? Anybody else? Yeah, what did it do for you?
Socialization.
Some more social contact. Great. So, mood regulation, social contact, relaxation, peace of mind. Who doesn't want that? That's our birthright as human beings, to have those qualities in our lives. You have to begin where people are at, just as what you said. For some reason, they came to the conclusion that that substance or that behavior is what's going to give them what every human being should have. And then, of course, the second question is, inevitably, well, how come you don't have peace of mind? What happened? What made you feel so insecure? What made you feel so isolated? Well, stuff happened. You're not crazy. You actually have adapted to your circumstances the best way you knew how. Now, that may be doing you harm, and you know that, but you're not crazy to want those qualities in your life. And that's what it means, harm reduction. You just begin with that conversation.
Yeah.
So in addition to the individual response, we also think of harm reduction without using that language necessarily at the cafe, is to think about how do our program structures, how do our rules, our guidelines, our policy support knowing that our members are going to be folks who are traumatized, who have individualized responses to their histories. So things like expecting that our members are not going to like when we control their behavior, expecting they're not going to like that we ask them to contribute in some way to the cafe with chores, and just allowing for that and having another option so that it's not a rigid system, but a system that recognizes people are going to bounce up against it, and that's part of the disorder, part of their behavioral adaptation.
Yeah.
I'm thinking about a meeting that I had today. I had a meeting with 2 treatment providers from out of state. They came in to market their services, their inpatients. They're about $30,000 a month. So when I think about what's best practice, what's the best way to treat the person that walks in your door, walks in our door, and all the services that would be required to spend that individualized time with them, and it's quite expensive. And I think that I was born in Holly Park. That's when Holly Park wasn't New Holly. It was quite a place to grow up. And nobody in Holly Park went to treatment. Nobody in Holly Park could afford $30,000 for a 30-day stay. So when we think about all of the things that you're hearing here today and what might be a best practice, you folks, I think, most of you young folks here are going to be the ones on the front line, might be seeing these folks first. And you might want to be thinking about those folks that are in front of you. They should be able to get the same kind of care no matter where they go. We should be asking those critical questions no matter what door they walk into or what seat they sit in front of. And the services should be the same. And, I know that at the Recovery Cafe, they absolutely treat everybody that walks in that door as if they were a king or a queen. They are a member of that family. I've seen it happen. And that's the model that we try to put forward as well. But I want you to know that to do that, that individualized care, to be able to spend time and sit with somebody like that, it's expensive. And so we might want to be thinking about some policy changes to make that more affordable and more standard and across the board for everyone, and not just those folks that can afford it, or not just those folks that cross some kind of a line like criminal justice or whatnot. Before they get to that point, recognize it at the school level, before they get to the juvenile justice piece, before they get to prison or whatnot. And so I'll pass that back.
Would anyone like to? That is actually a great lead into another question that I had, which is about feasibility. That here we often find that those who particularly need treatment are oftentimes least capable of accessing it or least capable of adhering to it. So how do we bring feasibility of harm reduction models to people who are in those sorts of situations?
It's a good question, but there's an assumption, which is that the people who most need it and are the least capable of receiving it, well, doesn't that mean there's something wrong with the treatment? Isn't there something wrong with the approach? I mean, do we expect the client to fit in with the treatment, or do we get a treatment that fits the client? So again, we create a system that's based on the utter denial of trauma. If you look at the definition of addiction from the American Society of Addiction Medicine, it's a brain disease, 50% genetically determined. Well, if that's how you see it, you're just not going to see who you're dealing with. And then you create treatments based on that model, and they don't work, and then you think, well, these people don't fit in with the treatment. It's not feasible. Well, consider that your treatment approach and the perspective on which the treatment approach is based on is not actually reality-centered. So it's like the schools, like the schools are increasingly dealing with a lot of kids with behavior problems and impulse regulation problems and attention problems and so on. So these kids don't fit into the schools. Well, the problem is not that the kids don't fit into the schools. The problem is that the schools were created under a model that no longer meets the needs of these kids. So the feasibility does not come from trying to fit the treatment to people to whom that particular treatment is not appropriate. The feasibility happens when we create treatments that actually meet the actual experience and needs of the people that we're dealing with. And it's extraordinarily difficult to do that in a context of social prejudice and judgment and utter ignorance about addiction and drug use in general. And it's also difficult to do it when the funds go into something as retrograde and harmful and documentably so as the so-called war on drugs. When all the money, that's where the money goes, that money is not going to go where it's needed. So that not only that war on drugs creates more drug use and keeps people addicted for the very simple reason that according to the research literature, and it shouldn't take a genius to figure it out anyway, that the biggest trigger for relapse is stress. So how are you going to create a treatment program in the context of a system that continually stresses people who began life as traumatized in the first place? And you continue to traumatize them. And then you think, oh, gee, our treatments don't work. Oh, gee, I wonder why not. So the problem is that it's not just an issue of the medical system or the public health system. It's also a systemic problem of a society that A, misunderstands drug use and addictions, and B, spends much of the financial resources it has in retrograde practices that only exacerbate the problem and have nowhere shown to diminish it in any way whatsoever.
So in terms of feasibility, I think it's very important to think about very much matching the treatment to the person, which is a very imperfect science. And our assumption, the starting point, the most low threshold, widely available treatment is 12-step is AA. And the challenge is if you go to AA and you don't do well, you're in denial. And so it pathologizes the person further. And what I've seen is 12-step is fantastic for the people it works for.
Yeah.
Great for those people, but it doesn't mean it works for everybody. In fact, we know it doesn't work for everybody. And from a drug policy perspective, I think it's been a lot of irony in watching marijuana legalization in Washington State begin to unroll. I'm seeing one of the biggest proponents of harm reduction being the Liquor Control Board. It's not Department of Health, it's not the Division of Behavioral Health and Recovery, it's the Liquor Control Board, which has an alcohol model that stresses moderation. And they put out little cards about here's how much you can drink and here's your blood alcohol level. There's a lot of groups out there that this idea around trying to figure out how adults can use marijuana safely just does not compute. You can see smoke coming out of their ears when you talk about that. But we have interventions. Roger Rothman from School of Social Work has done a lot of work on the marijuana checkup that actually tries to get people's marijuana use under control. I'm going to get these stats wrong, but it takes you, studies were finding, huge decreases, people dropping from 20 days of marijuana use to 10 days, and when they did use, using less, right? So trying to also think about that. For some people, that might be a very appropriate goal, whereas abstinence may not be a great goal for that person, for that substance. So just really trying to be extremely open-minded to what's out there. Again, everybody brings so much to this topic that evidence and research is often just sort of thrown by the wayside because I've seen something and it worked for this person and therefore I know it works.
So in terms of policy and access and feasibility, I feel a little more hopeful. It seems what we're seeing at the cafe as we look for support for our programs, which is very expensive because it's labor intensive and individualized, but hopeful because it seems that there is a move toward supporting, making reimbursable interventions like peer support, valuing community, finding ways to articulate what does community support look like and how do we quantify it, because that's how those who make policies have to think about things. How do we quantify peer and community support as an essential part of healthcare that we will be reimbursed for? And I think that's the beginning of making something like harm reduction feasible, because it allows us lots of layers of intervention and meeting people where they are.
He's the guy that started the question. So I wanted to ask another question about to go back to abstinence-based methods. In what way do those abstinence-based methods and those policies perpetuate homelessness or other health inequities that exist?
Well, I mean, if you require abstinence in order to get housing, that would be a way to do it. The flip side of that would be 1811, a housing first model in Seattle, right? So some people are hopefully familiar with that. And the idea there is that you take people who are using and you get them housing and they're allowed to continue using. Because requiring sobriety in order for a person, or abstinence for a person to get housing is pretty amazing. When I first started working with heroin users in '95 as I think, fairly well-functioning social work student, as much as a social work student can be well-functioning, I was struck by how much we were asking these people who were addicted to heroin to change. I could not make all these changes. Change where you live, change what you do, change how you think, change. You're asking for massive change. So let's give them some stability. I mean, something like housing, a housing first model is absolutely a harm reduction model. And so just trying to think about that, again, transforming that. Well, why do you have to be clean to get housing?
I was in San Francisco, and a doctor there told me that they did a study and showed that not only housing, but the more beautiful housing you get people, the less drugs they're going to use. For some strange reason, and of course, in places where there's wet housing, where we know this, people will drink less. So that when you make these impossible demands on people, and naturally you can exclude them from housing situations that would actually benefit them from the perspective of they would use less or maybe even give up using.
Anyone else? So how does housing fit into the harm reduction model? And is there an importance of that?
Well, the Portland Hotel Society, which is what I worked for 12 years, is a society that began with 2 street nurses, actually. One is a psychiatric nurse. And they were out there giving out bandages and sometimes clean needles and cleaning up wounds and so on. Then they realized, how can I help people if they have no place to live and if they have nothing to eat? So they developed the Portland Hotel Society as a housing society. And they took over this old hotel, and they renamed it the Portland Hotel because it was based on a model actually pioneered in Portland, Oregon. And they're going to accept people not based on how clean they were, but on how dirty they were, if you want to put it that way. So the people that are housed in the Portland are very often people with extreme drug use issues, with multiple mental health issues, sometimes with HIV or hepatitis C, and sometimes all four. And the intent of the housing was to give them a safe place to sleep, some nutritional support, and therefore the capacity to bring them into contact with medical care. So that the housing, but the housing was seen as the essential first step, and I think you have to see housing as the essential first step. You just can't do anything when people are, you're very limited what you can do. Now again, it's a matter of trust, because there are some people who prefer to stay homeless. Not that they prefer to stay homeless as such, but coming to the shelters might not be very clean, or they might be abused by others, or they might be exploited by others, or they just may have a lack of trust because they've been hurt so much in their lives, or they may have mental health issues that takes away their capacity to make a fully informed judgment. So you certainly can't force people into housing, and then you have to give them services wherever they are. But for many, many, many people, you just can't get to first base without providing housing.
I want to share one thing really quickly that I learned as a researcher, since I know many in this room are researchers. A year ago, we started recruiting for our study in the emergency department, and I wanted to be a good researcher and get high follow-up rates. And so I required everybody to give me at least 3 phone numbers of some contact. And that was awesome, except that a month into our study, we had no homeless folks in our study. So we got rid of all of that, all of those requirements in terms of contact information, and now we have 60% of people in our study are homeless. So how valid would my results in my study have been if I had those contact requirements? I wasn't excluding homeless people, but I was. And my study would have been absolutely useless. The group at highest risk for overdose would have been completely excluded from my study. So just, you know, we made a lot of difficult choices in my first intervention study, but when in doubt, I've always erred on the side of trying to get something that is valid and generalizable to the total population. You know, it would be like excluding people with mental health conditions from addiction treatment studies. Who would do that? Well, that's what most people do. That's the standard. How else can you assess unique, effective, your addiction treatment? Well, there is no unique, effective addiction treatment because most people are coming with mental health and trauma and a lot of other things. So just had a little research side note on that, but encourage people to be really mindful of those types of things.
All right. So another question is, in Seattle especially, and this is again probably a very universal thing, drug abusers come in all shapes, sizes, and ages. And I was wondering, does the harm reduction model vary depending on how old the drug addict is? And are there certain means that you would advocate for someone who is younger, such as a homeless youth, versus a homeless adult?
Really good question. So again, you know, the population that we work with is 13 to 29, and usually we'll see the parents first. The parents come to us saying, here's this problem, and we want to fix it. And unfortunately, what we have here is a lot of great treatments for adults 18 and over, Suboxone, Vivitrol, but in order for an adolescent to get that, it would have to be off-label because the FDA hasn't approved it, right? And so, but it's a perfectly good tool. I think Mark Fishman from, where's Mark Fishman from? Baltimore. Mark Fishman has done some research with off-label Vivitrol, and although he doesn't have a protocol for it, he has great results, you know. And I'm recently talking with a pain management clinic on the east side that wants to replicate his services here, and they're getting a little pushback as well about using medication with folks that are under 18 years old. And of course, we all want to think 18 and under, we would like them to not use anything, and it's probably the safest thing for the growing adolescent brain, but it's not realistic. It's not realistic at all. So I think that one thing that clinicians can do is they can bring the family along by talking to them about some of Alan Marlot's research on relapse extinction. What I see a lot is if an adolescent comes into treatment and they have a relapse or they graduate from treatment and have a relapse, what they tell us is treatment doesn't work. That's the furthest thing from the truth. Just because they've had a relapse does not mean that treatment didn't work. It's about what they did with the skills and the tools, and it's about the follow-up. If this is a chronic illness that's lifelong, shouldn't we be having follow-up sessions? And shouldn't we expect, like a diabetic, that they're going to relapse in behaviors? And in my opinion, it's not about whether or not they used again. It's about what they want to do about that and how I can help. We need to stop looking at this adolescent adult thing as if one's not good for the other, but meeting them where they're at and finding better approaches to treat in adolescents in a realistic basis for who they are. They're at a developmental level where they want to try on things. Peer pressure is paramount. Look, I can sit in a room of adolescents and tell them my experience or where I grew up. I can give them a bunch of skills, but it's not going to mean anything because they're going to look at this gray hair and they're going to think, that can never happen to me. That can never happen to me. I'm invincible. So it's going to take people that look a lot younger, people that are still hip, to tell them something that they can relate to, and that's what's going to make a bigger impression. And then again, that doesn't mean that they're going to stop using. It might give them another example, something to look at. And so, it's a lot to think about.
I totally agree with Frank that there are developmental issues. For us, it's a little grayer. Our age group is 21 through the end of the lifespan. And what we've encountered regularly is that once someone begins to use, their development is arrested. So yes, we want to pay attention to developmental stages, but they are not linear for our folks, and they're not coinciding with their chronological age. So it's always a dance of getting to know the individual back to that same, what is this person's history? And they might be 40 years old, but they're 17 or 15 or 12 in their development. And so I think the answer is yes, and it's complicated.
I agree with Frank in your description of the problem, but I want to give you a different way of maybe looking at it. What we're really talking about is who people look to for orientation. Orientation is where do you get your sense of direction from, how to walk, how to talk, how to be like. Now, it's perfectly true that in our society, kids look a lot to their peers for all that. But that itself represents a social failure. It's a complete aberration in terms of human history. Because in terms of human history, children tend to be around adults all their lives and get their orientation and initiation into the real life from adults. Like in tribal cultures, initiation was done not by peers, but by elders. And indeed, kids look to the people with gray hair with a lot of respect. And if you look at the Native communities in Canada, there's still a residual respect for the elders. And although that's been heavily undermined by colonization. But the issue is relationships and who they're relating to. Now, at the risk of being seen like a shameless self-promoter, but there's another book I co-wrote called Hold On To Your Kids, where the essential thesis is very simple. The human child is an attachment creature. They need to attach to somebody because otherwise they don't survive. The duckling hatches from the egg, looks around and sees the mother duck, and imprints on the mother duck, and therefore follows the mother duck around, orients by the mother duck, learns to be a duck by following the mother duck around and emulating her. But if the duckling hatches with the mother duck absent, the duckling will imprint on whatever moves. Could be a horse or a dog or a toy, none of which are designed by nature bringing up that duckling to adulthood. That's what's happened in our society, is that because of a massive social failure and community breakdown of the family, the stress on parents, and the emphasis on socialization of kids through other kids. Kids have now become attached to each other, and that's what we see through the internet phenomena. That people are looking to Facebook for quote friends and who likes them, all that kind of stuff. It's not a technological problem, it's an attachment problem. Therefore, we can't give that up. We can't just throw up our hands up and say in despair that, okay, now we've lost them. No, in fact, you will find, Frank, despite your gray hairs, and let me tell you, at age 70, you're making me feel very, very old when you said that. But with your gray hairs, my guess is that when you sit down with those adolescents and they develop trust in you and they sense your acceptance of them, they actually will look to you for advice and information. It's not a matter of having to be hip, it's a matter of having to be present with them in a way that they can get something from. And when they sense that acceptance and that respect that I'm sure you have, that you exude, I just don't think that you're going to have such a hard time. In fact, I don't believe that you do in communicating with them in a way that they can receive. So it's a matter of relationship. It's not a question of age.
Alrighty, so last question before I open it up to question and answer is recently we had a death, a major celebrity death. Philip Seymour Hoffman died of a heroin overdose. And I'm wondering, how does a high-profile death such as this impact your work and how it's perceived or received?
Asking me? Who are you asking?
Anyone?
I got a call at 1 p.m. on Sunday afternoon from CNN while I was fixing my bike chain. That's how it impacts. And so it's the sort of thing that, it's obviously the definition of morbid, but it is also an opportunity to do a lot of education with the public. And one of the things, the story I wasn't hearing, and what I talked with some media about was heroin, dangerous, addiction, lifelong, chronic relapsing, all those things. But this was a guy who got 5 Academy Award nominations while in recovery. He had 20 years of an amazing career while not using. And yeah, you got to be vigilant in terms of your addiction. And I can go on ad nauseum about the dangers of heroin. But also really important in that story, I thought, was that this person had 20 amazingly successful years. And that was, and people knew that, but they weren't talking about that. They kept saying all the bad stuff. And I think for people who are using and trying to look for something positive in that, I thought that was a really important piece that was often missing. But it also is one of those, like, CNN didn't call today.
Yeah.
Nobody called today. That was a few weeks ago. So it disappears very, very, very quickly.
And it's not because nobody died today of an overdose.
Right, 100 people died today.
Because nobody famous died. And I had the same experience. People magazine called me when Corey Monteith died in Vancouver. Corey Monteith, TV star, young guy. What's the program? Glee. Glee, right? Right. So he died of an overdose in Vancouver. He's from British Columbia, I think. And so People magazine calls, and they want to know how Vancouver's heroin culture contributed to his death. I said, well, it's not Vancouver's drug culture. It's the fact that this guy, when you actually look at his childhood history, broken family, learning difficulties, probably ADHD, failed treatments, rehabs that don't get it, so on. And I said, of course, and why doesn't the media talk about this when ordinary people die, who don't have famous names attached to their bodies? Well, if you want to read what my experience with People magazine was, I do have a website, www.drgabormate.com. You go to the blog post. The first blog I posted was about Corey Monteith and People magazine, and they never used the interview. The reporter himself was very interested and empathetic. He interviewed me for half an hour. They never used it. Oh, we got busy. We had other issues. They just wanted. Very often when the media calls, they already have an agenda. They just want a quote that'll support their agenda. It's not that they want to find out what really happened. They just that, how can you support us in our agenda? So it's a fascinating phenomena of here we have a human being dying and people are not talking about it. And when hundreds of other nameless people die, it just, nobody calls you. So that itself is a comment about our social attitudes towards drug use.
All right, thank you. So at this time, I'd like to open it up for about 15, 20 minutes of question and answer.